This conference will now be recorded.
Welcome, everyone. This is Len Sierra for AnCan Cancer Foundation. This is our Tuesday, August 23rd session for high-risk, recurrent, and advanced prostate cancer. And we wish to acknowledge the support of Bayer and Pfizer. And now we're going to start with a new member, Alan C. from New Jersey. Alan, I'm going to ask you a set of questions, and you, just to keep you in the right chronological order, you can answer these questions as I ask them, okay?
Okay.
All right. So how old are you, Alan? And where do you live?
65. I live in Ocean County, New Jersey.
Okay. And, well, I'm not going to ask how you heard about AnCan. I know you were on with Peter last night. So, Alan, when were you first diagnosed?
June of 2018.
2018, June, okay. And you recall your Gleason score and your PSA level at the time of diagnosis?
The PSA was a 6.7. And then they did a 12-core random biopsy.
Yep.
It showed 2 cores. Originally 3+3 on one side, 4+4 on the other side. I had the biopsy sent to John Epstein for a second opinion, and he upgraded it to 3+4 and 4+5.
Okay. And did they tell you which was predominant, the 4+5 or the 3+4?
Well, the tumors later on, based on the MRI, they were both of them about 1 centimeter in size, and the cores, only 20% were the active cancers. So it was low volume but high risk, like Gleason 4+5.
Okay. And so which urologist did you see and at which institution?
It was a local. I think his name was Cha. I don't remember exactly. A local outfit.
CHA, Cha?
I believe so.
And have you seen any oncologists yet?
Yes, I've seen a William Lerner. Again, these are all local doctors. He's an MO.
Do you know if he's a specialist, genitourinary specialist?
He's not. He's
not.
basically a hematologist, oncologist.
Peter, Monica, we're getting background noise from you.
Sorry, I'll turn off my mic.
Thank you.
I mean, is it okay to name the doctors, or should we
sure.
just?
Yeah, we do it all the time here.
All right.
But in any case, one thing we always promote with this group is that you see a genitourinary specialist, medical oncologist that focuses his practice on prostate cancer, testicular, kidney cancer, bladder, because there are just too many advances in the field, and it's hard for anyone else, a general oncologist, to keep up. We may have some folks from New Jersey here who might be able to recommend a GU medical oncologist to you. We'll get to that later when I open it up to everyone.
Yes, that was one of my questions, if anybody could give me recommendations in the tri-state area.
Right. Now, Alan, have you had any scans?
Yes, I've had, going back to 2018, I had the CAT scan, the bone scan. They were negative. And then they did a 3T MP MRI with and without contrast. And that confirmed there were 2 lesions on either side of the prostate, approximately 1 centimeter in size, both PIRADS 4. and one of the tumors on the left side was basically abutting the capsule. So based on the radiologist report, he cannot rule out extracapsular extension.
Extracapsular extension. Okay,
That
but
is correct. That is
no
correct.
lymph nodes lighting up, no seminal vesicles.
Nothing that was shown on the CAT scan.
Okay, and have you begun any treatment yet?
Yes, I underwent hormone therapy, Firmagon injection, as well as 45 sessions of radiation, total of 81 gray, with the Varian machine. That was done locally in Ocean County Hospital.
And when was that done?
That was done October of 18, ended in January of 19.
Okay. And I understand the reason you're here is because after your radiation, your PSA has begun to rise. What was the nadir or the lowest point of your PSA after radiation?
In November of 19, the nadir was less than 0.02, so essentially non-detectable.
Yeah, very good. And that was 2019. When in 2019?
November.
November.
So approximately 8 months after radiation stopped. Well, actually 10 months after radiation stopped.
Right. And so what is your current PSA?
0.95.
Okay. And what are you still on Firmagon or any other hormone?
No, we stopped Firmagon in March of 2019. So I had a total of 8 injections.
So you stopped in March of 2020 because?
No, March 2019.
2019.
Correct.
So you were only undetectable for a couple of months.
Actually, the level started dropping below 0.1. So we went to the ultrasensitive test, and then the nadired at November of 2019. So I had stopped Firmagon for approximately 8 months, and radiation 10 months from that point when I hit nadir.
All right. So since March of 2020, you've been on a drug holiday. Is that right?
Yeah, actually March of 19.
I'm sorry, March of 19.
Right. The radiation ended January 19. Firmagon ended March of 19. And the nadir was hit November 19.
And Alan, have you had any genetic testing, genomic or genetic testing?
None.
None. Okay. We always recommend, and I think it's an actual part of the NCCN guidelines, that all high-risk prostate cancer patients have genetic and genomic testing to see if you have any germline, which is inherited mutations, or somatic mutations, which are mutations in the tumor tissue. Have any of your doctors ever even spoke to you about that?
I've asked my MO about this, and he basically said it was not needed.
I'm sorry, he said it would not be necessary?
That's what he said.
Okay, that's why we need to move you away from him.
You can get it for free now.
Oh, yeah?
Yeah, we can put a link in the chat so you can go there, and there's a free, and you'll even speak to a geneticist after it's done when the results are in.
Is that a simple blood test?
No, it's a spit test. They send you a tube, you spit into it.
Oh, okay.
Really easy. We'll send you the.
Yeah, you could also do a blood test, but I guess it's easier for saliva.
Okay.
Well, it's free. If you do the blood test, you're going to pay for it.
Okay.
Oh, okay. Well,
Yeah, they do the blood tests. You're right. They do it, but then you have to go through your doctor. Whereas if you do the spit test, your doctor is not involved at all.
Got it.
But he'll also want to have somatic testing, which I'm pretty sure is going to cost, that's not free.
I'm on Medicare with secondary coverage. Would that be covered through Medicare?
Yeah,
Mine was, yeah.
they'll cover it.
Okay.
Most of it. All right, Alan, so we got a pretty good picture of where you are now, where you came from, and besides besides us recommending GU medical oncologists for you, did you have any other specific questions for the group?
Yes, I do. I basically had a PYLARIFY PSMA scan because of the rising PSA. So I was concerned because since nadir, it was steadily increasing. And, my doctor basically ruled, they were using the Astro standard of, 2 points over nadir, which would have been PSA of 2. And as my PSA was rising, I even inquired about doing an Axeman PET scan. This was back in, I believe, 2020. Unfortunately, the insurance would not cover it unless the PSA was above 1. So then, since then, the PSMA test came out in December of I think it was 2021, UCLA, but it wasn't available in New Jersey. And at that time also, it was not covered by anyone else than Medicare. So I was only able to, get on Medicare last October. So I was able to, get the test. I was actually waiting for a facility in New Jersey to offer that test. So in the meantime, in September of 2021, I had another 3T MRI with and without contrast. It didn't show anything. The PSA was 0.3. At that point, I consulted with Fox Chase, Dr. Chen, the urologist. And basically, he reviewed my records, and he basically told me that, again, the astral guidelines of 2, he said, you have nothing to worry about. Essentially, you are cured, was his, his quote. Okay, so then the PSA continued to rise. So we've been doing frequent PSA every 2, maybe 3 months to get a chart. Same lab quest to see the rise, the acceleration, velocity, etc. So I've calculated the doubling time from approximately 0.5 to 1 at about 7.5 months, which is not a good sign. So when the PSA got to 0.95, I had the doctor, the MO, ordered the PYLARIFY at the AMI in New Jersey, and I got the results recently. Can I read just a short paragraph, the impression of the radiologist, and get the group's feedback on what exactly he's saying?
Okay, go ahead.
Okay. He writes, more likely to represent a left sacral ganglia, comma, less likely a malignant node, and the internal iliac distribution is a 4.2 by 6.3 millimeter density with a SUV of 1.9. Similar structures suggested on the right in a similar location with a similar level of uptake. Towards the apical region of the prostate / superior penile bulb, biased just left of midline, an intense 11 millimeter focal uptake is seen, SUV value of 20.2, comma, the area of uptake on the CT scan vaguely correlates to potential 14.4 millimeter density. The finding more likely represents disease and or less likely urine activity.
Could you tell me once again that SUV of 20, where was the
That's the area in the prostate, the intense focal uptake, 11 millimeter area.
in the
The apical
prostate?
region, right, apical region, still within the capsule. He's saying it's finding more likely represents disease and or less likely urine activity. Now, 20.2 is considered very high, and for those people, SUV is the standard uptake value. It's how much the scan glows when the Polarify is injected into the body.
Right. Okay.
Does anybody have
What did
similar
you say the
findings?
level
And
was?
I'm sorry,
When you had the Polarify scan, what was your PSA level?
0.95.
Okay.
Alan, are you comfortable with Fox Chase? Is it very far away?
Well, I'm not comfortable because, like I said, the doctor came to the conclusion that
Okay.
I'm
What
totally
about a
cured.
better What about a better doctor? There's some good doctors at Fox Chase, and probably Joe could talk to you
Yeah,
about
if I can get some recommendations. Does anybody have any experience with a Dr. Mark Pomerantz up at Dana-Farber? He's an MO.
Yeah, he's excellent.
Oh, good, because I've scheduled an appointment to see him.
Isn't that kind of far away for you, though?
Yeah, it's a 5.5 hour drive, but their office won't do a telemed. You have to go drive up there and see him. I don't know why.
If you're interested in going back to Fox Chase, the really prominent GU medonc there is Geinisman, Geynisman, Dan Geinisman.
Okay.
And he's
Gey? Gey?
Geynisman, Geinisman.
Is he a urologist?
He is a medonc. He is a
Okay.
GU medonc.
Okay, good.
Okay, so he, especially given your level of you said you're a 4 or 5, right?
Yes, on one side,
Okay,
4
yeah,
plus 5.
I would definitely go see him. He's the guy I use.
Okay.
Yeah, and I
good.
used him also, Joe, and he was excellent, I thought.
He's really he's got good cred, and he's got a good, call it bedside manner, but he's got a good style. Okay, and he will take the time to explore it with you.
Okay, good.
Yeah, and
And,
I got up
somebody
got a
had-
little something and he called. He actually picked up the phone and called me.
Okay. Did somebody
Yeah.
indicate they had a good experience with Mark Pomerantz in Dana-Farber?
I'm not, I was the one who told you he's excellent, and that was going by reputation. He does a lot of clinical trials. He's well known in the field. I don't know for sure that anyone in our group went to him.
Okay. Okay.
If you're relatively close to Fox Chase, if it was me, I would go to Geinisman, because you're going to be in for the long haul. This is not like a curable situation. So you're going to be, you don't have to go to them all the time, but you want someone within reach who's dependable. You can bounce things off, because different treatment strategies might come up at various times, and you want to be able to bounce off things like genomic testing and this and that, and you just want someone who's going to be in your court for the extended trip here.
Does anyone have?
This is John. I agree with with Peter. I think Alan, probably once you get to a GU specialist, you're probably going to find your treatment gets more intense. And so having somebody 5 hours away might be a real pain.
And Geinisman, as you just heard, I think from Alan making a comment, communicates very well. He will, besides making an appointment with you, he'll see you, he'll call you, he'll email with you. He's got.
Yeah, another thing I really liked.
Stars.
I really like Geinisman. For my radiation, he said, listen, coming down to Fox Chase, I'm like an hour and 3/4 away. He said, no, that makes no sense. I'm going to send you up to Penn State Cancer Institute. That's where you're going to get your radiation. Just what we do, but he's following me for the hormone therapy. So he's sticking with me.
Yeah, and if you need another PSMA-PET, they do that at Fox Chase.
Okay.
Len,
Yes.
it's Bob McHugh. May I speak for a second?
Oh, yeah, sure. I didn't know you were on, but you went to Geinisman, right?
Yeah, I just switched to my care, as you know, from Mount Sinai, where I've been for years. which got impractical to Geinesman. And I echo everything that was said about him. He's great. His credentials are impeccable, and his bedside manner, nature is really as good as any oncologist I've ever come across.
Okay. Does anyone have any experience with the Sloan Kettering in Monmouth, which is only an hour away from me? Not the one in New York. This is the remote campus in Monmouth.
We've heard on this call that it's preferable if you're going to, if you want a GU medonc, that you would go into the city rather than to the North Jersey. They do a lot of the treatment, but for management of your care, I can't remember his name now up there.
This one is actually in Central Jersey.
Yeah, well, yeah, there's two Sloan Ketterings, North and Central. But again, most of the guys that we've talked to have found it preferable to go into the city,
Okay.
just to meet with a medonc.
Okay. Does anybody have any comments on the my radiologist's findings? Because the language he uses, I don't know, is it possible that this is a false positive?
You mean
Well,
on
the
the,
SUV of 20 is definitely not false positive. That's pretty strong.
Okay.
Some of the others
Now,
sounded like they might be inconsequential because the SUV was very low.
right. Those two, because of my understanding, they could be, like he said, a sacral ganglia. But the 20.2, so it's unlikely it's a false negative. There's something going on.
Yeah, you can always get another radiologist to read your scan too.
That was another question. Is it worthwhile to have another radiologist read a Polarify? I've been told, and I've read that the Polarify, essentially, it's self-explanatory. You're not going to get any benefit from somebody else reading it. You're going to come to the same results. Has anybody found that to be true, or
I
not?
think most of us have heard the opposite, Alan. And in fact, I don't know if they've fully developed it yet, but they were working on artificial intelligence reading of the Polarify scans because they were kind of difficult to read.
I see. If
Anybody
I were
want
to have it reread, any recommendations were?
I think someone like Geinesman would be able to explain it very thoroughly to you.
Yeah,
I
I
think that the
was just going to comment that it's a very Asian name, so I'd have to put it in the chat. He goes by Mike, but that's not his name. Who is the nuclear med guy who works with Geinesman at Fox Chase?
Okay.
So they do the PSMA-PET there, and I would, if you're gonna go talk to Geinesman, I would make sure that he also passes your scans off to Mike. I'll get his name, but
If Rick were here, Rick would
Go ahead, Jeff.
probably be able to give you some answers, but he's not here today. You might want to email him.
Okay. My MO in a very brief few minutes telephone conversation basically said I have a hot spot. He wants me to do another 3 Tesla MRI with and without contrast. Basically, from what trying to say that the Polarify doesn't give you the border of the lesion, and the MRI is supposed to be able to hopefully show the border, so there would be a possibility to biopsy the area.
you might also consider doing a micro ultrasound, which will give you a visual. It gives you similar to what you see from an MRI, but you'll see a greater detail with that of the lesion.
Okay, so what you're saying is do the micro ultrasound instead of the 3T MRI?
I'd consider it. Yep. And if you're talking to Dr. Chen again at Fox Chase, they do that very heavily there, and they do it in the office. So you don't have to go to the OR.
Okay, sounds good. Because that was my other question. The MRI uses gadolinium, and I've had a few gadolinium scans already with Dotarim. Now, this facility that did the Clarify told me they couldn't get the room. They're using something called Clarascan, which is FDA approved but never been tested. And I'm a little concerned. Is the gadolinium going to cause, buildup in the brain from, repeated exposures? Anybody have any insight? Because I've read that you can actually do MRI without the gadolinium. Doesn't add
Then
that
you
much.
don't get the detail from the contrast. But there's a major debate going on for years about whether or not gadolinium is a high risk or not. And there's about 6 different flavors of gadolinium. Can't think of it right off the top, but there are some that have the already are what they call gated, which has a block to minimize the crossovers. You're going to get a lot of counter opinions about whether or not it's a concern for the brain.
So you're saying,
Best thing to do is just get to a good doc and figure out a treatment plan at this point. Not, I wouldn't try to guess scans and this and that. Just get to someone who really knows their stuff and see what they recommend.
okay. Sounds good.
Because how actually would it affect the treatment plan? If this scan was done or not done and what it found or didn't find. I mean, we know perfectly well that there's a prostate primary. This is probably this is probably it, right? I'm not sure that the treatment plan would even be affected depending on the outcome of this scan. In a funny kind of a way, it didn't tell us anything we really know, except that the radiation didn't shrink it up to nothing. You know what I mean? I mean, we try not to get ourselves worried about a diagnostic test that's not going to affect the treatment plan. What do you think, Len? Or Joe, do you think it would affect the treatment plan depending on the outcome? Because I don't think so.
Yeah, sorry, John. What I would do if I were you, I'd get myself an appointment with Gynesman. You can do a telemed, but I would go in and see him because he coordinates with everybody. He will then be able to give you some really good advice based on assessment of your particular condition. Okay. Eric Harwitz is been around for, I kid him, about a century, but he's one of the premier guys in radiology as well. He's there. The nuclear med guy is there. You got enough if you can let the GU medonc help guide you through and see what he says. And then you can look if you want to look for other alternatives. Because if you just want to shop around, you can do that. But I would at least get an assessment before you decide to look for more.
Okay, because they scheduled me for the MRI next Monday, so I guess I would maybe try to postpone it to see Gynesman before that.
Give Gynesman a call. He'll probably talk to you same day.
Okay. I'll do that.
And then
Do that tomorrow.
And he may say, yeah, go ahead with the MRI. They do all of that over at Fox Chase too. But he may suggest, just defer it. But if you're looking for detail, okay, when you do it without contrast, you're going to get less of an image. Okay, that's what the gadolinium does. It provides them another series of pictures with much more detail.
Well, my understanding is they need that to calculate the PIRAD score.
The PIRAD talks to you about what the image size that it sees. A 5 says I see a lot, 4 says I see pretty good, 80, 70, 80%. A 3 says maybe I see something, maybe I don't. And 1 and 2 said we can't detail anything. And a lot of that depends on who read those scans. Okay. My guess is that if you go over to Fox Chase again, they're going to say, send the scans over to us and let us see what you already have. Okay. Because to get an MRI done, first thing you need good equipment, and that's only the beginning. And then you need a good doc who can read it, someone who's done like hundreds and hundreds of them, not 50 a year. And I don't know your guy, how much he's done, but interpretation of those scans is also very important.
Again, somebody has to help me with this question. Who cares about a PIRAD score at this point? We already know that we have level 4 and level 5 disease.
Yep.
And where it is. The PIRADS is only intended to help us know where to look. I think we're past that, aren't we? Who cares?
I agree with you, Dr. John. I agree with you. I think that's
not only that, but the Polarify scan is normally done along with the CT for anatomic localization. So I don't really understand why you need the MRI. That's a question you can ask the next doctor you go.
Yeah, your PSMA-PET is much, much more detailed than you'll get with a CT or a bone scan. Much more.
You mean
Yeah,
MRI?
the CT scan is done. It's a low resolution CT scan. It's done with the PSMA-PET for anatomic localization. The PSMA-PET doesn't give you that. It gives you, it'll pick up small lesions, but you can't be sure exactly where they are. That's why they do the CT, or sometimes they'll do an MRI, but sometimes insurance won't even cover that because the MRI is more expensive than the CT. But anyway, I think we've given you a lot to think about here. Alan, we've got to move on. We've got more new guys. Okay.
Thank you.
Alan,
You're welcome.
Alan, if you need any more information on from Fox Chase, this is Joe G at AnCan.org. Okay, I'm a regular patient over there, so I can give you some insights if you need it.
Okay, I see his name in the chat. I'll look him up tomorrow.
And welcome to the group.
Thank you.
All right. Richie, Louisiana, you're also new. Is that right?
Yes.
Okay. So I'm going to go through the same set of questions you just heard me ask Alan. All right. So how old are you? And well, you're in Louisiana, but where exactly in Louisiana do you live?
The North Shore in the Covington area.
Okay. And how old are you?
I just turned 69 Saturday.
All right. Happy birthday.
Thank you.
When were you first diagnosed, Richie?
I was first diagnosed in 2018.
Okay. What was your Gleason score and PSA level at that time?
My Gleason, I had a 3+4 and a 4+3 on 2 samples that were positive out of 12. And my PSA at that time was 4.9.
Okay. So they considered you 4+3, 7, right?
Yes.
Okay. And which doctor did you see?
My urologist was Dr. Porter. He was with the Baton Rouge Clinic.
Right, your medical oncologist?
Urologist.
Right, I understand, but who is your medical oncologist?
Dr. Love, L-A-U-V-E. He's with Pennington Biomedical Pennington Cancer in Baton Rouge.
All right. And do you know if he's a GU medical oncologist?
I don't know.
If somebody can look that up while we're talking with Richie, that'd be good. How far are you from Tulane University, where we have an excellent GU medical oncologist?
45 minutes.
45 minutes? Okay. Got a mental block on his name. Peter, John, somebody. Yeah, the guy at Tulane,
It'll come to me.
Oliver, Oliver Sartor.
Sartor. Yep.
Yeah,
What was his
yeah.
name?
Oliver Sartor, Sartor. He's one of the top oncologists in the country. He's involved with many clinical trials. He's a thought leader. He's a good guy to see, especially if the guy you're seeing is not a GU specialist.
I've heard the term GU several times. What does that stand for?
Genitourinary, so it means the medical oncologists who are GU specialists practice primarily with prostate cancer, testicular cancer, bladder cancer. Yeah, they focus just on that. And as I mentioned to Alan, there are so many advances in prostate cancer that no general oncologist could possibly keep up with all that's going on, along with all the other cancers they have to deal with. Okay.
Dr.
God,
Love is a radiation oncologist
Oh,
at Pennington.
uh-huh. Well, I guess we'll get to that right now. So you had radiation, Richie?
I chose seed therapy, but when they did the volume study, my pelvis opening was too small and my prostate was too large to get 100% coverage. So then I did the research between having the prostate removed or EBRT, and I chose EBRT. And
Okay.
that happened in from February to March 2019.
All right. And how many sessions did you have?
I had 5 days a week for 9 weeks.
Okay, sounds like IMRT. And what was the outcome of that?
Didn't have any side effects, and during the EBRT, my PSA jumped up to 12. But once it was completed, I started seeing that decline. In April it dropped to 5, and I'm looking in January it dropped to 2.5, August 1.3, February 1.2. May of 21, 0.99. So I was really happy with what was going. My PSA was declining, and they released me from the oncologist and said, just go to your urologist. In January of this year, I had a little spike to 1.1. And then on August 10th, just 2 weeks ago, 1.3. So I don't know if this little bounce is anything to be concerned, and that's why.
Rick talked about this last week. This was exactly what he said. If you have radiation and you still have your prostate, that you'll drop down to a certain level, which for you seems to be 0.99. And if you have 3 rises after that, you need to actually take action. You've had 2 rises. Last week, Rick was talking about it says it needed 3. It's you and your doctor, but that's what Rick talked about specifically last week.
Okay.
Your lowest PSA was 0.9, you said? 0.99?
May of 21 was 0.99.
And that was the lowest point.
Yes.
And have you been on any therapy since then?
I was never on any estrogen or hormone therapy. Strictly when EBRT ended, that was it.
Okay. So in 12 plus months, you said that was May of 2021?
That's correct. 0.99 was May of 2021. And they have me now doing a PSA test every 6 months.
And when was the last one?
Last week, 1.3.
1.3.
I wonder if I
You
don't
have a
know.
very slow doubling time.
Yeah. Still, even though the doubling time is slow, I kind of wondered whether 3-month, now that Richie is trying to figure out if he's having just random post-radiation fluctuations or whether it's an actual recurrence, maybe 3-month schedule for PSAs would be appropriate. I don't know, what do you guys think?
Yeah,
Would that just cause
absolutely.
more worry?
Absolutely.
Okay. I also told the panel the other day that I'm a bicyclist. And when I was going through EBRT, my oncologist said, stay off the bike for 6 months. And I think when I gave my blood sample a week and a half ago, I went for a 25-mile bike ride. So could that be affecting my PSA results?
Possibly.
Yeah, maybe.
Richie, have you had your testosterone checked?
No, I haven't.
It might be a good idea to get some kind of a baseline for the future.
Now, Jim, I just had blood work done a couple of months ago, and they have all the different the lipids and all. I'm wondering if my testosterone could be in that chart.
Probably not. It's a special request. Usually a special one. I get it essentially every month now. Okay, just for grins. But
And Jim, what does that tell me?
that will tell you eventually with the treatments that you could have, especially ADT wise, you will know how far it should come up, okay, after it's down, after it's close to zero. Okay, if you do ADT, which is probably coming along eventually.
Okay.
So Richie, if you had that 25-mile bike ride right before the PSA test, you might want to request another PSA test in just a month from now, to see if it goes back down to 0.99 or even less before you decide to do it, get scanned. I mean, you do have the option of getting scanned, but it may not be necessary if your PSA really hasn't risen in the past 12 months plus.
Len, how many days before my PSA test should I stop working out at the gym or riding my bike?
I don't know. Does anybody have an answer for that? I would guess 3 or 4 days, maybe 3 days.
Yeah, I was going to say 3 to 5 even.
Nothing less than 2 for any activity, sexual, bike riding, or even heavy workout. In one of the groups I was in, we had a guy who was saying, oh, I don't have any of those kinds of conditions, but my PSA went up. And we said, well, fine. Well, what'd you? Oh, well, by the way, the day before I was helping my son take down a brick wall. If you stimulate the prostate, it's going to create PSA.
Okay.
Okay, but the first and most important thing you have to do, Richie, is get yourself to a genitourinary medical oncologist specialist. There are a few things I don't like, and I'm sure most of us here don't like what we're hearing, like PSA tests once every 6 months, and no ADT or hormone therapy while you're being radiated. For guys with the Gleason 7, it's been proven that they're synergistic. When you use radiation with EDT or hormone therapy, the patients do better, at least in 7, 8, 9, or 10.
Amen.
So, yeah. So that's priority one for you, I would say, is go down to Tulane, go see Dr. Oliver Sartor, and come back and tell us what he says.
Okay, thank you.
Any other questions?
I just wanted to say that, Richie, I guess, that it doesn't matter exactly. No one is saying you have to change your primary treatment physicians yet. That you really should just get to an expert for at least an opinion, and then see what's going on. We don't know, what he's going to say, but that second opinion, it changed my life and it might change yours. It could be extremely important. Seems like they're a bit sluggish. If you're low 0.99, it's not that low. It's low, but it's the same thing that everyone's recommending, maybe another PSA test. But I think to get to a real GU medonc, genitourinary medical oncologist, is really extremely crucial, in my opinion. At least to just make sure you have somebody who's really an expert in your back pocket.
I just moved from Baton, and my life is upside down. We moved recently from Baton Rouge to Covington, and I just switched. I met my urologist for the first time the other day. I'm looking him up real quick. His name is Ross Hogan, and he's board certified. He's a urologist. I don't know how to look and see if he's a GU.
Well, that doesn't apply. That doesn't apply to urologists because they are GU. But why would you see a urologist? Do you have urinary problems, retention, leaking, anything like that?
No. I belong to a group in Baton Rouge, Louisiana. It was the men's support group. And, I haven't had to catheterize myself to empty my bladder. I've had no side effects. Knock on wood, everything's working pretty well. My concern is my PSA. And
right. So there's no reason for you to see a urologist going forward. You just need to see a medical oncologist.
Okay.
Let the medical oncologist be your quarterback, as we like to say, the one who decides or mutually decides with you what other doctors you may need to see, if any.
And that medical oncologist should be a GU.
Yes.
Okay.
I don't think I asked you, Richie, if you had genetic or genomic testing done?
No, I did not.
Do it.
Yeah, do it, as Jim says. Talk to your doctor about getting that done. Sartor or whoever you go to.
Okay.
There's a link in the chat to get it done for free from Promise.
Yeah, that's true, but you do not get somatic testing that way, and you should get it. I know.
Right, but you'd have to pay for both if you get both done. If you just get somatic, if you only have to pay for somatic if you get the free Promise.
He looks older than 65. Richie, are you, or are you a young guy?
He's 69.
69, no problem, and Medicare will pay.
Okay.
Richie, any other questions for the group?
No, you've given me a lot of information. And like I said, I used to belong to the men's group up in Baton Rouge, but we just moved and now I'm remote. So I appreciate joining in on the meeting and listening to the conversation and the suggestions. just one last thought. My oncologist in Baton Rouge released me to the urologist a year ago. So,
Well, according to Peter, what the guy you thought was an oncologist is actually a radiation oncologist, not a medical oncologist.
okay.
So yeah, that makes sense that he would refer you back to your urologist, because at that time you didn't have any recurrence in any rise in your PSA.
Right.
Okay. Peter, did we have any other new guys tonight that are on? I know there's a Tony, but he's not here, right?
There was another new guy, but he wanted to keep quiet. Maybe we could just
Oh.
ask him sometime before the end if he had any questions. I
Yeah.
just don't remember his name.
Mr. Lappa, who said he was on a while ago, Stan Lappa, who hasn't been on, who was on once before or something.
Yeah, he said about a year ago, I think.
Yeah, I'm the new guy that said I wasn't going to talk.
So you're new, but you were here about a year ago?
No, not me. I've never participated in this before.
So you're brand new.
Yes, although I'm not brand new to prostate cancer.
Okay.
Neither are we.
Yeah, I was diagnosed in 2009.
Okay.
When I was 56, after getting my first ever PSA test. That was stupid. There's a lot of stupidity associated with my history of prostate cancer. But anyhow, prostate was removed in 2009. I had salvage radiation in early 2013. Was recommended to have androgen deprivation therapy in late 2016, early 2017, when my PSA had risen from its nadir, which after post-surgery, the nadir, and post-salvage radiation, the nadir was about 0.12, and it had risen to be about 7. And at that point, that was my urologist, and that's the point at which I started to see a medical oncologist, because I said, you know, this guy cuts and he works with working plumbing, but I need somebody who works in a different direction.
Yeah.
So it sounds like my direction is what you're recommending to people, and that's really positive. It's really valuable kind of reinforcement to me, and I really appreciate that.
Stan, let me interrupt for a moment. You said the salvage was 2013, PSA 0.12, and then you went to 7. What year was that?
That was late 2017.
Okay, go ahead.
So anyhow, I started seeing a prostate oncologist at that time, and concurrently with that, dropped eggs from my diet. One of those things that I guess works for some people, not others. My PSA actually hit an apex of a little over 9, and it dropped slowly to the high 6s over the next 2 years or so. But
with no treatment.
I'm sorry?
With no treatment.
Correct.
Okay.
Then after that, I moved to California, and the PSA began to rise again. It got up to the 9-ish range, and had a PSMA scan that identified 4 metastases, all distant from the prostate bed. 1 in the lower left lung, 2 in lymph nodes that are right next to my esophagus, and 1 vertebral involvement. And I evaluated the possibility of going to metastasis-directed treatment, talked to a couple of radiation oncologists about that approach. But then I also initiated Leuprolide, and at that time, Casodex. And I've basically, I spent about a year on Leuprolide, and I've added in abiraterone, Zytiga, about 9 months after I started the Leuprolide. And then I got off of the Leuprolide after 12 months on it, and I've been on abiraterone ever since. And my testosterone and PSA remain non-detect, and I've been advised there's no purpose served in going back for another scan. I actually did have one scan done after my PSA and testosterone dropped after being on Leuprolide, and those metastases had shrunk to the point where they were no longer visible in the PSMA-PET scan. So that's where I am today.
Well, that's good.
It is.
Now, what did you tell us your Gleason was? I forgot. Your Gleason.
Oh, I didn't say. At the time of the biopsy, it was scored at 4+3. It was rescored at pathology to 4+4, with and there was no extracapsular involvement. The surgery, the indications were that they got everything, which of course they didn't.
Yeah.
Where are you being treated? What doctors are you seeing?
Well, I started my treatment with a doctor in Marina Del Rey, Dr. Jeff Turner.
Schultz, Jeffrey Turner, but he left. So now Schultz is running the show.
Yeah, and I frankly didn't much care for Schultz. So
yeah, Turner was great. He was my doc for 8 years.
Yeah, he was. I then migrated to Dr. Dorf at City of Hope. I've just recently had a falling out with their practice because of inattentiveness to my prescription dose. They filled a prescription while I was present, or while I was on vacationing in Europe, and when I got back, I found out the re-prescription was to the wrong dose. So I'm basically going to stick with my general practice oncologist locally in the California desert. I'm in the Palm Springs area. And I anticipate establishing a relationship, I think probably with the Prostate Cancer Center at UC San Francisco. So any thoughts about that?
Another guy that some of us really like, I've never met her, is Dr. Raina McKay down in San Diego. She gets a lot of mornings.
It's actually, believe it or not, easier for me to get to San Francisco because I can get a cheap round trip flight for, practically nothing. So, but what's the doctor in San Diego again?
Raina McKay, R-A-N-A McKay.
I think this is John. I think Dr. Dorf has pretty good credentials. Was it her in particular that caused the screw up, or somebody else in the office? I mean, should we throw out the baby with the bathwater?
Dr. Dorf has excellent credentials, but when I've been prescribed, and I don't need to go into the details, but suffice it to say
hopeless, huh? Okay.
Suffice it to say that she was inattentive, and I don't have time for that.
Okay. I think you're our first guy that has been on abiraterone monotherapy. Is that right, Len and Peter?
I think that is right, but I think it's a good strategy, because why do you need Lupron when you've got Abby keeping your testosterone down much better?
From a different place.
Yeah, the other thing that my current oncologist believes is likely, obviously the operative mechanism for abiraterone is that it serves to some extent prevent cancer cells from utilizing testosterone. But in addition, he believes that it's likely that abiraterone serves to delay the onset of castrate-resistant disease.
Yep, that's been
That's the
proven.
purpose.
That's been proven in clinical trials.
Now, that's good to hear.
Yeah.
Well, there's great GU medoncs at UCSF. I mean, you can't go wrong there.
But Peter or someone else who knows UCSF, I have in my notes, probably from Rick, that Dr. Agarwal at UCSF is very good.
He's the top, yeah.
So if Stan prefers UCSF, try Dr. Agarwal.
Very good. It's Jeff, by the way, but no problem.
Oh, wait. I thought I was talking to Stan Lappa.
No, not yet. This is Jeff. Jeff didn't want to speak originally, but now he's with us.
Yes, my shyness has dissipated. Thank you all so much. I appreciate it.
Yeah, where
So
else?
Stan Lappa is the guy I was just interviewing, right?
No,
Huh?
no, it was this guy all along. I don't think.
Yes,
we
it's been
ever-
him all along.
Yeah,
Where else can you find 36 shy guys talking about their prostate cancer?
because we don't have any testosterone.
Okay. So what's the last name of Jeff, who we're just speaking to?
It's Hullinger.
Okay. And you were the one that's brand new, is that right?
I'm brand new.
Okay, so Stan Lappa was the one who told me he was here a year ago. Is he still on the call?
Yeah.
Yes, I am.
Oh, well, I'm going to have to ask you to wait till the end if we get to you, Stan, because normally we don't deal with more than 2 new guys because they take up a lot of our time, and we need to get to all the other guys who have who need some time. Okay.
Stan said he was only going to do an update.
All right. How much time do you need, Stan, to give us your update?
Oh, just a couple minutes.
Okay, go ahead.
Yeah, prostatectomy in September 2019. Salvage radiation last summer, 2021. Undetectable since then. Gleason 9. Sailing along pretty well, and then just last Thursday, PSA of 0.25. I got on the horn and made an appointment with a urinary guy, Peter Van Veldhuizen, University of Rochester. I'm meeting with him on Monday. So that's about it.
So you were undetectable after SRT in 2019.
No, I had a prostatectomy followed by radiation a year later.
Right. That's what SRT is, salvage radiation therapy.
Oh, right. Yep.
And that was your last treatment. You were on nothing else after that?
Right. Yeah. I was on Lupron for 4 months. preceding the radiation. And yeah, like I said, I've been undetectable until last Thursday. So it's kind of given me a startle, and I'm back visiting you guys.
So you got
Okay.
3 years, and then just had a re-increase, and
Yeah.
you're bummed out, of course.
Yes. Yeah.
All right, so you've already got an appointment with a medical oncologist?
Yes. Monday. I actually see my radiation oncologist tomorrow, who's been just keeping checks on the PSA. And I'm just surmising what he's going to tell me, that it's time for an oncologist. So I thought, with Ben Nathanson's advice, take the bull by the horns and make my appointment before I even see this guy tomorrow. So I did it, and they can see me on Monday. So
Can you come back next week and tell us how it went?
sure. Yep.
Okay, thank you.
All right. Thank you, guys.
Thank you, Stan. We'll see you next week.
I just want to say it's not great being here with you guys. So thank you.
Yeah, that's why we used to be called the Reluctant Brotherhood.
Yeah, I go to them on Wednesdays. Thanks.
Oh, does John still use that name?
Oh, yeah, sure, of course.
Yes, he
Every
does.
Wednesday.
Yeah. Sure.
Okay. All right, let's jump over to Dennis McGuire. You said you have an update for us, Dennis? Are you there, Dennis? All right, we'll get back to Dennis. Let's see. How about Jim Barnes? You had an update?
Yeah, I did. I'm just going to tell you that on my third round of chemo here, and PSA is going down. Started out at 3.8, now it's down to 0.9. So
Very good.
Chemo sucks, but it works.
Yeah. So how are you managing with side effects so far?
It's rough. Yeah, it's just constantly tossing and turning. So I'm really uncomfortable, and it is what it is.
Okay.
So,
well, it's doing the work that it should be doing, so stick with it and keep us posted.
we'll do. Thank you.
Are they giving you 3 days of dexamethasone, like the day before, day of, and day after?
Oh yeah, I was bouncing off the ceiling for 3 days for sure.
Okay. How about Les Shelderoff?
Okay, the last time we talked about that I had been diagnosed with the cancer going to the left testicle, and there was bouncing back and forth because of different complications, if I should go with radiation or surgery. One of the many complications was significant involvement with the spermatic cord also. Anyway, I went for different opinion. Dr. Russell Smolovitz had a video conference with him, and there were a few things that was notable that I found out from him. He had indicated that he had never seen prostate cancer metastasizing to the testicle before. He said, in my 15 years practice, I'd never seen it. And he asked some others there in the background that no, hadn't either. Anyway, he had indicated, are you familiar with the brain barrier? And I said, yeah, I'm aware of it. And he said, well, there's something similar to that to the testicles, which I had never heard of before. That normally it does not go to the testicles. And when we had discussed the different options that I had been given between radiation and surgery. And I had asked him about the possibility of chemotherapy. And he said, well, that he wouldn't really recommend that either because, again, in the same token as the brain barrier, the chemotherapy may not get to the testicles, which that had never been discussed before either. So I didn't know if anybody else had ever heard of that before.
News to
Anybody
me.
know anything about testicular cancer? Don't they use chemo for that?
That I don't know.
Yes, they do. Yes.
They do. So why would
There
there
was
be
a-
this penetrable barrier? It's weird.
Yeah, I don't know. Anyway, sideline to that, I've had some additional problems since I talked to even with Dr. Smelovitz, more significant impact to my testicles. So I've decided to go with the surgery at the Mayo Clinic. Things are progressing a little faster than I had anticipated. The left testicle is about 2.5 times the size of the other one and it's starting to give me discomfort. So I think I better act quick. But I was just wondering if anybody had heard of this other thing with the not going to the testicles. I had never heard of that before.
No, neither have I. Anyone else ever hear of that?
No. Les, are they talking about like just removing that one, or are they talking about a full orchiectomy?
No, I asked about that and they said, no, they're just to take the one. But the big complication there, or one of them, is the involvement of the spermatic cord. And I still don't know how they're going to go about that. That it was, and they showed us on the MRI scan that it was quite prominent that it was way up in that spermatic cord. So I don't know how they're going to do that.
When are you going to be at Mayo?
Be the 15th of September. That was the earliest they could get me in. Anyway, that's all I've got. If there's no other comments. Okay.
Well, let's keep
Anyone
in
else?
touch. I'll see what my calendar says. If I can get down there to visit, I'll do it.
Okay, well, good luck, Les.
Okay, thank you.
Is that Mayo Rochester, Mayo Arizona?
Rochester.
Okay, Les, good luck, man.
Yeah, thanks.
All right, Julian Morales, are you ready?
Yes, I am. I went to see Dr. E last week, my medical oncologist, and she says I'm doing real good. My PSA has been undetectable for 6 months. And she says in 6 months, I'll be able to come off of the darolutamide and the Orgavet.
Fantastic.
Yes.
All right.
How long would that mean you were on the drug therapy, Julian?
2 years.
2 years? Oh, that's what they planned for me too.
Yeah, 2 years.
John, you're on Darrow right now also?
Yeah, maybe Julian and I will be going off meds the same time.
We'll celebrate.
And John, are you on monotherapy or
No.
you're taking? Okay.
Yeah, Dr. Petrolak wouldn't go for the monotherapy. So he'll just take me off both of them if my next PSA is still good.
Yep, same here.
Okay. And the Orgovix, that's been keeping your T levels down?
0. Undetectable.
Your T levels, I'm saying, testosterone.
Yeah, testosterone is undetectable. It's under 10, I think. It's what the lowest they go.
Huh, wow. Never heard of an undetectable T level. How about you, John Antonucci? Is yours low? That low?
Yeah, they call mine undetectable also. I think it says under 12 or something like that.
Under 10.
Okay, well, that's good news.
Yep.
Thank you, Julian. We'll go to Pat Martin.
Yeah, just a quick question. I'm going to see my medonc on the 9th of September, and I've lost about 25 pounds over the month of July. He's looking at putting me on immunotherapy, Keytruda, but I read about a preclinical trial by Dr. Matthias Stefan, STEPHAN, through University of Washington Med Center.
Oh, Pat, somehow you got muted.
Okay.
So how much weight did you say you lost?
About 20 pounds.
20?
Yeah.
In 1 month?
Yeah, it was in 1 month.
And that was
in
from
July.
Keytruda?
No, it was from just being sick. I got, it started with the UTI, and then it went to serious diarrhea and vomiting, and then dehydration and stuff like that. And then I couldn't hold anything on my stomach. So I've been able to hold stuff on my stomach the last 2 weeks, kind of. And I've been getting better, getting stronger. But this preclinical trial by Dr. Matthias, STPHAN, run through the University of Washington. He found a new way to engineer T cells without removing the T cells from my body, and interjected them with a nanoparticle load with mRNA payload that engineers T cells as they circulate. And I was wondering if anybody else had seen that test or seen that trial.
The first I'm hearing of it. Anybody else?
I got it in a fundraiser from SCCA, and it was just a blurb, preclinical trial. It didn't say how many people or what. Didn't name the trial, or well, it wasn't a trial, preclinical. Ran it on a few people. So, no, I'll see him on the 9th of September and see what's going on. No, I really didn't have the 25 pounds to give away.
Mm-hmm. Yeah.
No. Down to 155.
How tall are you?
5'10".
So could you put that info in the chat box about your clinical trial, or you don't really know what it is?
Yeah, I will. What I'll do is I'll see if I can send the blurb, send the email on to you guys. So that would be that way you could read it and wouldn't have to have me interpret it.
Yeah, we'd appreciate that. Thanks, Pat.
Okay, who do you want me to send it to?
Well, you can send it to me. Simple, len@ancan.org.
Okay.
I'll send it to all the other moderators.
Okay, very good. That's all I have.
Okay, well, thanks very much. And the UTI is all resolved now? That's behind you?
Yeah, yeah. I use a clamp because I'm incontinent, and I think that contributes to it. I get about 3 a year. And anyway, got to keep up on things. Stay hydrated. I don't like drinking water because that makes me leak and pee, and so one thing leads to another. Got to stay hydrated though.
Yeah.
Very
Okay.
good. Thanks for your time.
Dennis McGuire's back.
Yes, Dennis, go ahead. Thank you, Pat.
Yeah.
Hey, everyone. Just quick update. I completed my 6th Pluvicto at the University of Chicago last week. This is under the Managed Access Program with Novartis, which I started in December of last year. So now it's wait and see how long it holds in.
So that's your last treatment.
Yep. And my last PSA, which was last week, was 2.5.
And that came down from, what was it, about 60?
No, when I started in December, it was at 300.
Wow. That's a great response. And how are you dealing with side effects?
Pretty usual side effects I had after every treatment, 3 to 4 days afterwards, a fair amount of fatigue and some dry mouth in the morning. But drinking fluids during the day, the dry mouth is pretty manageable.
And so now that your therapy is concluded with that regimen, are you just drug free now, or are you taking anything?
I'm on Lupron.
Okay. So they just want to do kind of an active surveillance at this point, right?
Pretty much, I think I'll do monthly PSA checks and watch it.
Okay. Well, very good. I'm glad you had a fantastic response.
Thank you.
And I hope it's durable. Any questions for Dennis, guys?
What is the next treatment strategy after Pluvicto?
I don't know exactly. Personally, I think I would like to do more Pluvicto. If I can get that approved through Medicare.
Unfortunately, the research is not in yet to allow that to happen. In Australia, they said that they would be able to have reports about it in September, about the efficacy of it. That's what's just not been done enough, unfortunately.
All right. Well, meanwhile, enjoy the low PSA and let's hope it lasts. I have John Vandenberg next on the list.
Okay, this is John. I wanted to thank you guys for recommending that I stick with the abiraterone and Lupron, which I did in January. And I finished abiraterone here in June. And my PSA is non-detectable, which is great. My testosterone is slowly going back up. But I bring to the table maybe a little different question, which is after treatment, I'm still having pretty significant side effects, which I think are related to adrenal insufficiency. My blood pressure has plummeted. When I started with the ADT, it went up quite a bit. I tend to have low blood pressure, but it's running around 87 to 90 over 55 right now. So I'm fatigued just by that in part. But I'm also having repeated bouts of diarrhea and very, very much low energy and fatigue. Talked to my oncologist about it at the beginning of August, and he said that my taper for prednisone was probably too short, too quick. So he's
Yeah.
put me back on prednisone for this month, where I've taken 5 milligrams for a couple of weeks, and I just switched over to 2.5 now for the next 2 weeks, with the intention being that my adrenal glands will start to kind of ramp back up after they were suppressed by the abiraterone. So have any of you guys gone through this type of sort of different kind of consequences from stopping treatment, which is what I've done, really? That's my question.
Yes, sir. This is Jim Marshall. Anyway, I was on the Abbey for 57 months, ADT for 60 months. And going into Abbey, anyway, I had a BP problem. Okay, so I started the drugs, everything else. Okay, and then anyway, I had to ramp it up. So at this point in time, I've dropped off probably about 50% of the BP drugs. And the thing I've noticed is that I believe, okay, the cortisol, okay, hasn't kicked in yet, okay, even though I'm off of it. So indeed, I am tired. Of course, I am like 78, okay, in a mind of a 50-year-old. So, I mean, I try to push myself. So, yes, I am going through that now, and I've been slowly dropping off and with the BP stuff, although occasionally I will get, like today, it happened to get down to, the BP was down to 87/53.
Yeah.
And I was like exhausted.
Yeah, that's what I'm feeling. Yeah. So I guess the question is, how long does it take for the adrenals to sort of kick back into gear? Maybe individual, but that's what I'm
Now
kind
that
of
I don't know. Although I did have a consequence of the whole thing, because I have arthritis. Okay, and the prednisone was then helping that immensely, and now I don't have it, so it's kicked in again, and so I have to get it treated.
Try gabapentin. It made a major difference. I'm up to 500 milligrams, and the difference is hurting on every step and not hurting hardly ever.
Okay, gabapentin
for the arthritis.
for the arthritis.
Yes, no, they say it's not for arthritis. I've got arthritis in my knee, bad arthritis, and it's a miracle. But you've got to go up slowly. It does drop your blood pressure when you start with it. It did with mine, at least. And I went from 100 to 300, like waiting 5 days between each 100, 5 or 6 days, making sure my blood pressure stabilized before I moved on.
Okay.
It's been a miracle what it's done for my knees. I can walk. I go walking twice a day, a mile, and I can go as fast as I can walk now. And boy, it was just miserable when I dropped off of gabapentin.
Okay, I thank you very much.
Hey, John, this is the other John. When you got put back on the prednisone, did all your symptoms rapidly clear up?
I would say somewhat. I felt better, but here I just finished a 2-week course with the full dose, 5 milligrams a day of prednisone, and my blood pressure again is very low, 87/57, I think, this morning. So, yes and no. I mean, I had diarrhea, today, so it has resolved somewhat less intensely, but it's still there. And I'm seeing my primary care physician next week, and I'll talk to her about whether I should have an endocrinologist appointment or just wait it out a little bit longer and see if it improves over time.
Yeah, that seems good. I'm kind of dismayed that all your symptoms didn't immediately clear up when you got back on prednisone.
Yeah.
That would have
I've often
really cinched the diagnosis,
Yeah, that's right. I mean, I've had the diarrhea for quite some time, actually, and I attributed it to the radiation. I had 58 treatments, radiation treatments.
Oh,
And so that they kind of cooked me. That's what I feel like. And it wasn't
Recently,
just
you mean,
focused.
or
It was I had 33 treatments focused on the prostate bed, and then another 25 much more broadly because I had the PSMA scan.
when?
And, that was about a year and a half ago now.
Hmm.
Yeah.
My
John,
radiation diarrhea cleared up pretty quickly.
Yeah.
You see a cardiologist?
I have not. No.
You might want to find a cardiologist that you can talk to too, with consistent low
I
blood
take
pressure.
500 milligrams of gabapentin 3 times a day, period. Taking 100 milligrams made a major difference, and going up from there got better and better. What happened?
Jeff, you're talking about the arthritis, right?
I'm
Yeah.
sorry. I had my mic on and I was recording a message, and I'm sorry.
We heard it.
was
Peter, I
John,
have not gone to a cardiologist, but that's a consideration. But my primary physician, when I told her I was having problems with low blood pressure, I guess 2 years ago, she said I should increase the amount of salt in my diet as well. That may help some. My wife has high blood pressure, so we're very salt restricted. So I'm starting to pour salt on too, just to kind of bump it up a little bit. Amen.
John, were you taking 5 or 10 a day? Okay,
5.
with the Abbey. 5? Okay.
5. Yeah, 5. So anyways, that's it for me. Thank you.
Yeah, I'm curious now, guys. I would say ever since I had prostate cancer, started being treated for it, my blood pressure has been consistently on the low side, like roughly 100 over 65, 100 over 70, sometimes as low as 90 over 60 even. Is that anybody else experiencing low blood pressure like that since being treated? Pat Martin, yes.
Amen.
Jim too? Yeah.
Yes.
Okay, I guess everybody reacts differently.
Yeah.
I get it lower blood pressure in the afternoon. Every afternoon, it goes down to the below 100, over 60 something. It's are you on? You're not on Zytiga either, are you?
No.
Darolutamide you're on?
Nothing right now. I was on Lupron. Yeah, I had a Lupron shot in January.
No, that.
And then the Abbey ended the end of May. So yeah, I think again the prednisone I think is helping. And again, I'm on a long taper now instead of a quick taper, and hopefully it will give some time for my adrenals to kick back into gear here. Fingers crossed. Thank you.
Thank you, John. Peter, Kafka, looks like we have time for you. Was there anyone else who said they needed time and hasn't spoken yet? Okay, the floor is yours, Peter.
Let me get my mic back on. I just had to change rooms.
Okay.
Revolving Zoom meetings going on here. Vacate the bedroom and move into the room. Okay. My short story. Yesterday was my scheduled second immunotherapy Keytruda treatment, and jumped in the car after lunch and drove to the University of Minnesota. Got my blood tests, met with the PA. Good thing about there is you get your blood test results, your CBCs and everything within 20 minutes after they draw it out of you, which is pretty amazing. So I was all excited and anticipating to go. And the PA looked at my blood work and said, "Whoa, your liver enzymes shot up." So my ALT and my ASTs were up in 200-300 range. And she said, "No, we got to pull the plug on this one today. No infusion." And instead of that, she gave me a prescription for 80 milligrams of prednisone. So I'm on 80 milligrams, 80 a day. And I'll have an appointment with Dr. Antonakis next week. I haven't seen him in a couple of weeks, but I'll meet with him and see. So that's the downside of it. And the upside of my my labs was that my PSA went down from 1.56 to 0.68 after one Keytruda treatment. So that was interesting. But again, I haven't talked to the doc yet, so all I have is these numbers and things in front of me. So hopefully I'll be able to get back on schedule because the things seem to do something. At least it did something to my PSA. So maybe it's working. All these PDL inhibitor things, all this stuff I don't quite understand, the immunotherapy stuff. But hopefully I'll be able to get back on schedule. So that's my short story.
Very good, Peter. Anybody have questions for Peter?
Yeah, I do, Peter. I'm just curious, was that high dose of prednisone, was that to bring your liver enzymes down?
That's the idea, is to try to bring it back under control. I don't, so it'll be at least, I mean, if I go back and they're better, I'm going to have to get weaned off of the prednisone then, and then before I can get back on Keytruda. So it's probably going to be at least a 2-week ordeal, if not 3 weeks. So I don't know how this is all going to pan out.
How were your numbers before you took the Keytruda, the ALT, AST?
They were low.
Below 50, what you mean, right?
Yes.
I just looked it up and it looks like about 25% of people have that happen.
Right. The question is, does it happen often? Or, I mean, where you got to stop it all together? Or I don't know. Those are quite, I haven't been able to see the doc yet to talk about that.
Peter, how are you taking the 80 milligrams? Is that all at once or over several times during the day?
4 tablets, 4 20 milligram tablets all at once every morning.
Hopefully you're taking that with food.
Yes. Yeah, so that's, an aside story. I mean, the University of Minnesota Masonic Cancer Clinic seems like it's really a good institution. It seems to be great. That was my first impression. Yesterday, the guy that did my blood, I asked him if he's doing the work, CBC and everything, and he said, yes. And he didn't do the CBCs. And then he, I think he was stressed out over a divorce or something. Then he ended up throwing one of my vials in the trash. So he had to come back into the room where I was seeing the PA and draw more blood. And he still didn't do the CBC. Another phlebotomist had to come in and do that. So it was 3 draws off my port to get the blood work all right. So that was a little strange. And then I asked the PA about the prednisone. Do you take it with food? Do you take it? And she said, oh, no, you don't need to take it with food. And then when I got home and read the thing from the drugstore and read it online, it said, take it with food, take it with food, take it with food. So she didn't have her act quite together. And then she prescribed Then she prescribed Prilosec stuff.
Yeah.
And I realized that I'm already taking something of that nature, Pantroprazole. So why she prescribed me something that's already on my med list, I don't know. So it was a little weird. So I'm anxious to see the doc next week. I don't know if
Yeah.
people are coming right out of med school or what's going on there.
Yeah, I might ask for another PA.
Right.
Hey, quick note. A blood pressure of 97/57 is considered normal by the AMA. Any blood pressure over 120 is now considered high or elevated. It just blew my mind. I got a new blood pressure monitor and they tell you. And the AMA says anything over 120, you're too high. But 97/57 is just quite normal. That's all. Thank you.
That's amazing, really. Because you get around 90, you're starting to faint. That's my problem. Gotta be careful when you stand up quickly.
Yeah, I've had that experience too. And yet, anytime they take my blood pressure and it's that low, they never say anything like, gee, you got to get your blood pressure up. So I guess they do think it's lower end of normal.
Yeah. You just got to be careful. Look for furniture to hang onto when you stand up.
Amen.
So
no, it's when you bend over to untie or tie your shoes from standing, and then you stand up. Then you have to hold on.
Hold on to something. Yeah.
we have to get an update from our founder, Dr. Rick Davis, who had surgery today. He had a hip joint replacement, and here he is. What a trooper!
Yeah, you don't look too good.
No, guys. Hi, guys. They intubate you. So if my voice sounds like it does, it's because they stuck all these things down my throat. I didn't know anything about it.
Yeah.
All I knew was I was having a nice chat with the anesthesiologist who was very friendly, and then they say your surgery's over. So that's it. But I do want to relate one thing, of course. I have a funny habit, and I hope most of you do too, that I read what I write, what I sign when I go into these places. And they give you reams of paper, and there's a lot to read. And I just don't, I just will not just sign stuff arbitrarily. So I was a little bit late getting there, and I'm reading this stuff and signing the papers, and the nurse comes out and says, "Oh, Dr. Petcher wants to mark you up." I said, "I'm not done signing." I said, "I can sign it later." "Oh, no, you have to sign it first." Maybe you should have come in 3 hours early instead of 2. I thought that was a nice comment. So I said, "Well, you could have asked me to or sent me the papers ahead of time." The one thing there were a couple of things I wouldn't sign. I wouldn't sign the obligation to pay the overage, which I don't think they can do anymore anyway, those overbills. So if they bill more than the Medicare accepts, they can't bill you for that anymore because the law's been changed on that. But they had it in there, so I X'd that out. I X'd something else out. And then I'm lying on the table where they're getting ready to mark me up. And I'm reading that if necessary, I grant them permission to hospitalize me if something goes wrong, which makes perfect sense. Except if they're going to hospitalize me, I want to be in an in-network hospital. Because the next thing I know, they'll take me to an out-network hospital and I'll be facing huge bills. Oh, she says, "You can't write on that. Don't write on that. Don't write on that." I said, "Wait a minute." I said, "You're giving me something. I happen to like to read it. And then you tell me I've got to write it as signed. I don't think so." So this is my nurse. So I'm thinking, don't really want to piss her off, but I ain't going to do it. So she brings in my doc, who is great. and I have a good relationship with him. He says, "You're right." He said, "I had some friend whose wife got taken to an ER out of network. It cost him an arm and a leg." But, you know, the docs are reasonable. It's just, excuse me, with the greatest of respect, Mr. Ward, it's the counselors, you know, it's the lawyers. And they put stuff in there and they figure they're going to get away with whatever they put in because you're doing surgery. And that's it. But if you say no, they'll listen to you. So that's my story. And I now have not one new hip, but 2 new hips. So you can all say hip, hip, hooray.
I have done
Congratulations,
that
Rich.
before.
You not only were your a patient advocate, but you were also a junior lawyer advocate.
Yeah. Anyway, I mean, look, I have no idea. They said the surgery went really well. I'm sure it did. And, but I just, you know, I hate it when they take the patient for granted. You know, it's just wrong. And I can't blame the surgeons. It's the admin. Anybody else ever had that? Has anybody else read something and not been willing to sign it?
I have, and I have also crossed lines out and initialed my cross outs, and I have added words and initialed my added words.
Yeah, I've done that.
Basically gave it to them as if take it or leave it. And they've never said, "Oh, well, go home then and come back some other day." Maybe I didn't cross out anything really crucial, but I've done that.
Well, I think the problem is that the people that you're dealing with don't know whether it's crucial or not because they can't read these documents either.
Yeah.
How about you, Muslin? I mean, you're a document reader.
Yeah, I'm not the best document reader, but same thing. Looked at it, crossed it out. You get a funny look from the nurses. They come back and they say, "Oh, okay." You know, then I bet you the nurses have never read it, and I bet you 99% of the people never read it, and they just sign it. They're just not used to somebody reading it. Bet you lawyers do though. But it's just, it's ridiculous. It's just so
ridiculous. And I mean, if you think it's ridiculous here, my sister's getting her first hip replaced on October 2nd. They are 4 times more conservative in California.
Yeah.
Just in terms of the procedures for prepping, they're making her change sheets for a week in advance every night. She can't drive for 6 weeks afterwards. It's ridiculous. Because they're so much more scared of the litigation in California.
Yeah.
I like Julian's comment.
Yeah. Mortgage papers.
Well, David and I have done that. I don't know how many times when we're reading our own documents and we bring in our professional knowledge to our own documents.
Once again, Rick, you've proven that you eat your own dog food, meaning you preach your own best advocate, and you are your own best advocate in every endeavor in life.
Thank you, Lynn. Thank you, Lynn. Yeah, I like that. I eat my own dog food. Somebody may use that one. Or my friend Hallo I'm staying with overnight, I can see him telling me that later on.
So Jim is a lawyer?
Any other comments from this august crowd?
I had a question that came to my mind today about radiation.
Yeah, go ahead.
I noticed one of our new guys got IMRT and his dose was 81 gray, and it struck me as a hell of a lot of radiation. Is that what they're giving now?
John, I got 86 gray.
Oh, you did?
Sloan Kettering. No one else gives that dose but Sloan. I don't even know if they still do it, but they were, at the time I had radiation in 2016, that's what they were doing. I tried to talk them down from that. They said, nope, this is what we do.
Wow.
So 81 sounds good to me.
And I suspect that Joe Gallo and I on paper got even more, because I think we got 50 something from the Reiki and 46 or 47 from the IMRT, but Alan Liddell says you can't add them up. So I don't know enough about
Yeah, if
radiation.
you added mine up, it would have been 130, but they said, no, it's, you don't add them up.
Wow.
Hey, last week, palliative care was recommended for people here. And I'm wondering, with low-level prostate cancer, or well, advanced prostate cancer even, we're not having any side effects, where does palliative care fit in?
I think it fits in anywhere where there's an opportunity to improve quality of life. In your particular situation, Jeff, even better management of the hot flashes that you still deal with probably worse than most. But if you've got issues with weight management, you had issues with weight management for a while, it would fit in there. If you had issues with fatigue, it would fit in there. Any place where you feel that the treatment that you're getting has compromised your quality of life. Does that make sense?
Yes, thank you.
Interestingly enough, in that article that I attached this week, if you read it carefully, they're actually talking about palliative management. I've never seen this before. They're actually talking about palliative management for active surveillance and low risk disease. Peter, did you notice that, Peter Kafka?
No, I hadn't noticed it.
Because they're recognizing that, as we've done for a while, that anxiety can be a significant issue in active surveillance, early and early, very low and low risk.
So, Rick, did you ask them what type of anesthesia they were giving you?
Oh, screw it. No, I mean, well, I know what they gave me. They gave me a lot, but I didn't ask them what the meds were. They gave me 5. They gave me, excuse me, a light general anesthetic and a peripheral nerve blocker, and they gave me 8 milligrams of Dex. Why would they give me 8 milligrams? Why would they give me 8 milligrams of Dex for something like this, Len?
8 milligrams of what?
Dexamethasone.
Oh, dexamethasone? It's a good question. I'm not aware that they typically do that, unless it had something to do with the intubation. The reason I asked is I was wondering, what did they tell you ahead of time you were going to be intubated?
No.
That's why I was asking the question, because like if you got too much anesthesia, you know, maybe they did like, they were getting nervous and they wanted to make sure your respiratory system didn't shut down and they intubated you. But
I can ask Dr. Petro. He'll tell me. He's very straight.
Everybody is intubated for general anesthesia.
What was that, John?
Everybody is intubated for general anesthesia.
Oh, really?
Yeah.
Huh.
I think so.
I don't remember ever being intubated. If I've got propofol for...
No, you don't have to be intubated for propofol because you can breathe on it fine.
Yeah.
So while we're on the subject of anesthesia, whenever I go under for something, whether it's a colonoscopy or anything, someone warned me about the effects of Versed, and I usually decline Versed. I go in right away and say I do not want Versed because I've been told, and my experience is it kind of messes up your mind quite a bit. I mean, its purpose is to kind of put you out, and so you don't remember anything. It doesn't. You don't come back from it very fast, and it's not really needed. The anesthesia is enough without the Versed, but it's almost routine that they push it at you. I wonder if anybody else has any experience with that or thoughts about it.
I can make a comment. Versed is often used because of its synergistic action combined with opiates or barbiturates, and it's not essential. But you just have to use a higher dose of whatever else, and it is an amnestic medicine. You can't remember anything that.
You muted, John.
Whoa. There you go.
Oh, muted again.
Unmute him now. I think it was my fault.
Oh, okay. I kept going back to being muted again. Versed is midazolam. It's used synergistically with in surgery, usually relatively minor surgery. Propofol has taken the place of Versed barbiturate combinations and things like that in many cases, but it's an amnestic drug. You can't remember anything that happened while you were on Versed, even if you were semi-conscious.
Why do they use it, John? I mean, what does it add?
It adds it adds to the effects of the other drugs quite a bit, and it's a safer medicine than barbiturates or opiates.
Okay.
I've had two different surgeries, spine surgery and upper spine and knee replacement. Neither time did they intubate me. And after the spine surgery, they had to give me Narcan twice to wake me up. They had really overdone it, but no, I wasn't intubated.
Surprising to me.
So I've
How long
got a
did
good
that
Narcan.
system?
I've got a good Narcan story, but I want to just say that maybe they give you the dexamethasone. They gave it to me today to reduce swelling. Could that be?
Yes.
To control inflammation then?
Yeah.
Yeah, could be.
So last Monday, I had an annual physical. And so before the annual physical, I stopped off to try and get the 2 prescriptions filled that I needed. One was for the antibiotic, and the other was hydrocodone in case I have pain tonight. And the hydrocodone was a performance because in Arizona, it has to be an e-script. They won't accept a paper script. And so when I came back, of course, they hadn't filled the hydrocodone, and I'm like 40 miles round trip from the pharmacy, so I don't want to have to come back again. And I'd already looked up the price of the meds, and the price of the 2 meds was about $13 or less, $12 for the 2. Fine. So I'm trying to figure out what to do. I call the orthopedic office, and they've all gone home. And wouldn't you know, as I'm standing in Safeway, my GP calls me because she forgot to mention something. I mean, she's really good. She forgot to mention we need to set up a bone density scan, which is great. And I said, Dr. D, I said, would you mind doing me a big favor? Would you? I said, I can't. I'm in here, and they won't take the paper script. I said, would you mind filling the hydrocodone for next week? She said, no problem. So she does it, and they bring it out. They make me wait still another half hour. They bring it out, and the bill's $50-something. And I'm thinking, what's going on? Well, She did what most doctors are supposed to do but never do, which she filled the Narcan with a nasal. It's a nasal spray. I think it's $37. I didn't take it because I use so little of this stuff anyway. But I was so impressed that when she prescribed the hydrocodone, she did what the doctor's supposed to do and give you the Narcan as well. Anybody else have their docs done that when they filled?
Nope.
But you are supposed to, aren't you, Dr. John?
I don't know.
Oh.
I don't know. I mean, if there's a risk, for sure, you know, if doses are high, the person's already on methadone or something like that, yes. In a regular risk situation, I didn't know that was normal practice.
According to, I'll tell you how I know. Howard Walensky was writing an article on it, and he sent me the stuff, and he told me that the docs are supposed to do it. Now, that's what Howard said, so you can take that with a pinch of salt or not, but that's my source.
I've gotten Dilaudid without that. And Dilaudid is a lot stronger than your hydrocodone, which doesn't work on me hardly at all. And Dilaudid, I mean, that really works, but I can't say, I mean, you'd have to take a bunch of pills in order to have an overdose. It's just, you know, they give you 2 milligrams.
I know.
You can only get like 8 pills, right?
No,
Yeah.
she gave me 30, and in the RX that we fill, that Dr. Petro gave me and Dr. Davis rewrote, it was for 30 pills for hydrocodone. Different question. When you guys get your dexamethasone for chemo, how much do they give you?
Peter, you've had chemo. How much dexamethasone do they give you, or prednisone?
During the chemo, they gave me 20, but they also gave me a script for 2 milligram pills, so I could taper off during the follow-up, because I always wanted to have some control over coming off of the chemo treatment every 3 weeks.
Just curious. We don't have too many chemo guys in here today. No chemo experts other than Mr. Fish. Oh, no, David Muslim didn't get chemo. What did he?
The thing is, Rick, you know, if you OD'd on hydrocodone, how are you going to give yourself the Narcan? You know, you need someone else there with you to give you the Narcan.
To give you the Narcan. Yeah, but I think that's the idea. You're supposed to have it in the closet so somebody can give it to you. You know, I mean, she's sticking on my stockings, you know, with those pressure stockings, compression stockings, saying to me, you can't put these on your own. Well, I have no idea how the hell I'm going to get them off. I just don't know. I'll figure it out.
You're not alone in the house, are you?
Well, tonight I'm not. I'm staying at Al's in Tucson. I'll go home tomorrow. So,
Guys, I've got to go. I don't know if anybody wants
I was just going to answer Rick's question. I grabbed my bottle of dexamethasone here, and it's 2 4-milligram tablets, two times a day, before 1 day and day after the chemotherapy.
So it's around the 8. Yeah. But what they gave me was 8 grams intravenous. But I think they give you some more intravenous when you're doing the chemo too, Jim.
They
I
do.
think, but I'm not sure.
They do. They gave me 2 20 milligram tablets before and after, and a little bit more during it.
I mean, you could have swam out to Canada from with all that in you. All right, guys. Well, I didn't mean to bust up your meeting like this, but
I'm taking 80 milligrams now.
Finish, Rick.
okay.
Rick, you just
Good
got
night,
one.
everyone.
Rick, you just got one hip done today, right? You didn't have them both done, did you?
No, I had the other one done 4.5 years ago, January of 18. I had the
Gotcha.
other one done. This one was done robotically. Len, you can go. I'll just close the room in a second. This one was done robotically. So the first one, he hadn't started using the robot yet. He innovated it about 6 months afterwards. It's a Mako. It's a Mako Shark. Is the Mako? No, not Mako Shark. What am I talking about? Snyder. I forget. Anyway, Mako is the brand name. Striker's the company. Mako. The reason they use the robot essentially is basically for the trigonometry. So the robot figures out all the angles. So he opens you up, and then it gets you exactly even. Now I said to him, Dr. P, I said, had I known we were going to need the other one too, I would have asked you to give me an extra 3 inches the first time. He said, yeah, but then you would have been walking around in circles for a while. You're right.
Hey, Rick, you and I are, I guess, the only guys in the group that have 2 replaced hips. I have 2 also.
I know you had I know you had one. I didn't realize you had the other one too.
My first one was done back in 2007. Then I had to have that one revised in 2020. And then my other hip went in 2021, which I had done in November. So
I remember that. Was it a
so you must be under 65 years old then, because
no.
The hospital where I went, the rule was if you were over 65, they held you one night.
Well, they've changed all of this now. It used to be that the first time they wanted $5,000 if they let me out the same day. And I said, and it was $200 if I stayed in overnight. I said, I'm eating breakfast. So.
Oh, good for you.
This is much better. I mean, I slept, I got up to move around, and once I started getting up, I felt quite a bit better. So I thought, oh, I'll come in and say hello to you people.
Well, congratulations. Good luck.
Thank you. Peter, quick question. My first hip went over 3 years, and it was bone on bone. You couldn't see any cartilage. This one they did today went over like 3 or 4 months, really quickly. And it was just as painful, but I could see cartilage. Did that happen to you?
That's interesting. Mine was a slow, steady breakdown. You know, the first one I did, I was only 57. I was diagnosed 9 years earlier, and I was told you better get used to living with this because you're too young. So I waited 9 years, and it was a slow and steady decline. And by the time I got to really bone on bone, I said, I got to do it now. Enough is enough. But
I think that's what a lot of people don't understand. The quality of life is so huge.
Oh, yeah.
There's no point in waiting.
That's right.
My brother Gene, who you know from the other group,
he
just had his second hip done about 4 or 5 months ago, and it went really quick. But his first hip lasted, was done a couple of years before, and it went a long ways. So it's similar to what other people talking about. You don't have the same results on both sides all the time.
Yeah.
Well.
All right, guys, we got to clear the room out. Because we got the MS people coming in. I'm going to just say hello to them and then get off. All right.
Good night, everyone.
Thank you for your good wishes. Much appreciated.
Good night. Good
Rick,
luck.
take care. Good luck.
And put that bottle of vodka down, please.
What was that, Mr. Captain Gallo?
I said, put that bottle of vodka down off the screen.
Yeah. From your mouth to God's ears. Okay. Goodbye.
Enjoy. Good night.
Thank you. Bye-bye.